So my name is Erin. I'm a genetic counselor at Duke University. I work very closely with Dr. Kishnani. And so today I'm going to be focusing a little bit more broadly on the genetic aspect of HPP and talk about some of the different ways it can be inherited and what we've learned so far and what we have yet to learn about HPP. So if you have any questions, please feel free to submit them and I'll make sure to address them at the end. So with that, I will go ahead and get started. So first I'll start with a brief overview of HPP, very similar to Dr. Kishnani's overview. So HPP is classified as an inborn error of metabolism or a metabolic disorder. A lot of the time in genetics when we're referring to metabolism, you think about diet and food, but there's also metabolism of bone. So metabolism refers basically to any process that has to do with building up or breaking down of substances in the body. And so HPP is a disorder of bone metabolism in that it is a disorder of the formation, the proper formation of bones and teeth. As we're all aware, this results in a very wide variety of symptoms and severity and age of onset. So each person with HPP presents a little bit differently. If you've met one person with HPP, you've met one person with HPP, and their symptoms are very different across the age spectrum and across the lifespan as well. So there's a couple of different subtypes of HPP that have been described in the literature. We use these pretty loosely, and I think Dr. Kishnani touched on that very well. So I'm just going to go through and summarize kind of what we generally expect for each subtype. So perinatal HPP is on the most severe end of the spectrum. The onset is typically in utero and can even be detected on prenatal ultrasound whenever bones are not properly visualized. This form is unfortunately often lethal. When babies are born, they're born with very severe bone hypomineralization, and they might have very difficult times trying to breathe. If you think about poor mineralization of the ribs, their lung function is not as great, and they are unable to sustain an airflow. And unfortunately, many of these babies do pass away. We then have infantile onset HPP, which can range anywhere from birth to 6 months of age. Of course, while babies are growing in utero, they still do have HPP, and some of that might be apparent early on, but typically it's not seen until a little bit later. These children can have rickets or bone bowing, kind of like the radiographs that Dr. Kishnani showed you, and of course hypomineralization of the bone. Generally, infantile is still a pretty severe form of HPP, and many of them are able to now receive treatment and live longer lifespans. However, there are still some significant complications. Up next, we have childhood HPP, which is where a lot of the overlaps, I think, really begin between symptoms. So children with HPP typically have premature loss of teeth, and that's one of the very first symptoms, which is what Dr. Kishnani mentioned. So I've had parents in the clinic bring me an entire tooth with a root attached to it and say, this is not right, what is going on with my child? And in a lot of cases, that's typically the first sign, and that's due to that poor tooth formation, as Dr. Kishnani explained. Some children will have unexplained fractures, aside from, expecting the fracture, like if you are a child and you fall out of a tree you were climbing and you get a fracture, that's one thing, but if you're running with your friends on the playground and fall and get a fracture, that's a little bit different. So a lot of the times these are atraumatic fractures and they can become apparent very young. Adult onset HPP is another one that, again, we kind of get into that overlap range. Some adults will not develop symptoms until much later in life. They can experience multiple fractures, poor dentition as well, and of course bone and muscle pain. However, a lot of these adults, whenever we're meeting them for the first time for their diagnosis, they're looking back and saying, oh yeah, I did lose some teeth really young, or I did have a fracture that seemed a little bit more severe than we thought it would for what happened. So in a lot of cases, these adult onset presentations actually were onset in childhood or even adolescence, and so there's quite a bit of overlap between these two, and it can make it really difficult to really put a specific patient in a specific subtype. And then on the mildest end of the spectrum is odontohypophosphatasia, and I think that this term is almost becoming kind of obsolete. If you were present for Dr. Kishnani's talk, we know that Previously, odontohypophosphatasia has been classified as individuals with tooth abnormalities, so premature tooth loss or poor dentition, multiple cavities, without any skeletal findings. But what we've come to find so far is that as people age throughout the lifespan, they can start experiencing some of these symptoms that are typically seen in childhood and even adulthood. They can start experiencing pain and fractures, and they aren't considered mild symptoms. I wouldn't consider a fracture a mild thing. This continuum of disease here, I mean, that's what it is. It's a continuum, and I think it's becoming more and more difficult to put patients in individual classes of hypophosphatasia. So again, we'll talk a little bit about the variability of HPP, not just from patient to patient, but even within the same family. So a parent and a child, both with HPP, or two siblings, can both experience very widely different presentations, which is kind of interesting in terms of a genetic perspective. If you have two family members with the same genetic finding, you might expect them to have similar symptoms, but that's not always the case. And then, of course, we know that these symptoms can evolve over time, making it even harder to classify a specific genetic mutation to a specific subtype of HPP. So it's really important, kind of the bottom line here, is to continue monitoring for symptom development throughout the lifespan. And we'll touch a little bit more on that later on. Of course, this slide you might be familiar with. I borrowed it from Dr. Krishnani's presentation, so I'd just like to highlight a couple of the other findings in HPP that we're aware of aside from the bone manifestations. So one of them is neurologic features. So in some of the more severe ends of the spectrum, typically in that perinatal and infant, we can see seizures, increased intracranial pressure, or even craniosynostosis, so poor formation of the skull or abnormal formation of the skull plate, or even intracranial hemorrhage. We can also have muscle involvement, including severe myopathy, chronic pain, immobility, so a lot of patients end up in a wheelchair or on crutches or have difficulty walking, and then delayed or missed motor milestones. And I'll say that that's pretty broad across the lifespan, but also parent and young children who maybe they weren't walking on time or didn't start crawling on time. So that can also be an early indicator of HPP in children. Of course, we're familiar with the skeletal manifestations, the undermineralization of the bone, poor healing of fractures, atraumatic fractures, chronic pain, and osteomalacia or osteoporosis, which can be seen on DEXA scans or bone density scans. We also have the respiratory difficulties that are, again, more common in children, so respiratory failure and hypoplastic or underdeveloped lungs due to that poor mineralization in the chest or the rib area. Typically, this is treated very early in life, and some require oxygen support early on. We can see some challenges with the kidney function. One of them is nephrocalcinosis, or the buildup of those ectopic calcifications that Dr. Krishnani talked a lot about, and also renal failure in some more severe cases. Of course, the rheumatologic symptoms, which are some of the earliest symptoms, and often the source, I think, of a lot of misdiagnoses of HPP as well. A lot of people presenting to the rheumatologist, and this is probably true for a lot of you listening in now, and being diagnosed with osteoarthritis or rheumatoid arthritis, and then later on finding out this was HPP, but the symptoms can be very, very similar. So we've talked a lot about the clinical diagnosis of HPP, but what is it when it comes to the genetics? What do we mean when we say genetic testing? So we're going to explore that a little bit more. So HPP is caused by mutations in a gene called ALPL. So you'll see me use that throughout the presentation, and just to make it easier to reference back, anytime you see it italicized, I'm talking about the gene name, the ALPL gene. So this gene is responsible for producing the enzyme tissue nonspecific alkaline phosphatase. And similar to Dr. Krishnani, I will use this interchangeably. I've underlined ALP because that's generally what we say and what I hear patients say a lot. So anytime I'm talking about ALP, this is what I'm referring to. So the ALPL gene, when it's working properly, it makes this ALP enzyme, which we know is needed for proper bone and tooth mineralization. So when we don't have enough, or we have some abnormal ALP, that is what leads to the symptoms of HPP. This is the only known genetic cause of HPP. There is not multiple genes involved that we currently know of, but we do think that there are some other genes that might influence ALPL activity. So there's a couple of different research projects going on right now that I'm aware of looking at collagen genes. So those genes are involved in the buildup of the stuff that holds the bone and muscles together rather than the bones themselves. So there's some potential there for some modifying genes, but that is not something that we test for clinically at the time. But I do think as we go on down the road, we're going to be finding out a lot more information about genes that could modify the ALPL gene. So this slide is another repeat from Dr. Kishnani. This is just a reminder of the underlying feature of all patients with HPP is this decreased ALP, which is, we do a blood draw to find that. And so you can see a couple of different areas here. ALP levels, the normal levels, change throughout the lifespan if you think about people, children as they grow and adults as they turn, young adults as they turn into adults. There's a lot of different changes happening in the body. So we see quite a peak here. Quite a peak here around 4 to 11. I don't know if you guys can see my clicker. Is when the ALPL levels are the highest, and then it starts to level out down past age 20. So it's very, very important if your doctor is drawing an ALP or you get one done as part of a complete metabolic panel. It's really important to make sure that those norms, that those values are specific to your age and gender as well. And so, because if you see, if you're in your 20s and your reference range is, they're using a pediatric reference range, that's not going to work for you. Similarly, if you're a child and they are comparing the reference range to an adult with a adult reference range for ALP, then you're not going to get a proper reading for that. So real quick, I'm going to give a kind of general genetics kind of overview. So this is going to sound very similar to high school biology class. So bear with me. If any questions come up, please send me a message. One of the speakers can or interrupt me, and I will happily clarify. So first I'm going to talk about chromosomes, which if you're coming to see me in the genetics clinic, I may or may not talk to you about chromosomes, but this is a picture I use a lot of the time because it's kind of familiar. A lot of people say, oh yeah, I remember seeing that in my biology class. So this is a picture of what's called a karyotype, or all of our chromosomes basically lined up very, very pretty, and we take a picture of them. Chromosomes are the packages of DNA. So all of your DNA, all of the instructions for your body are packaged in these tiny little chromosomes, and these are found in every cell of your body. You wouldn't be able to see them. We would need a microscope to look very, very closely at them. But essentially what you're looking at here is a person's entire genome. So if you recall, we get half of our DNA from our mom and the other half from our dad, hence why everything is in pairs. So chromosomes 1 through 22 are what we call autosomes, and those are of course 50-50 from mom and dad. There's one each. And then pair number 23 are what's called the sex chromosomes. Typically XX indicates the female development and XY indicates male development. There can be chromosome disorders, so entire extra or missing chromosomes. So if you think about an extra chromosome 21 is associated with Down syndrome. So hypophosphatasia is not a chromosome disorder. It goes a little bit deeper than that. It's a specific gene that's actually on chromosome 1. 1 second. There we go. So this is obviously not an accurate arrow, but it's pointing kind of in the region that the ALPL gene is located on. So basically, if you were to take this chromosome and zoom in really, really closely, you would be able to see the specific ALPL gene. So of course, we have 2 copies of that. So when we zoom in on these chromosomes, we see these individual genes. So of course, this all is still DNA. So I think of DNA as the instruction manual for our bodies. It tells our bodies how to look, how to grow, and how to develop. DNA, which is kind of the twisty molecule here, that's a pretty common cartoon people see and think of when they think about DNA. The DNA is made of individual genes. And so each gene has a specific job to do in the body. So the genes are made up of the genetic alphabet. Some of you guys might be familiar with, are these 4 letters. when you get a genetic test report, you will see the variant or the mutation that has to do with these 4 letters that make up the gene. So that's what all those crazy letters and numbers mean in your genetic test report. So genes are responsible each for a specific job or function in the body. So a really simple way to think about it is a gene for brown eyes contains a set of instructions for how to make brown eyes. Genes for 10 fingers and toes contains a set of instructions for how to make fingers and toes. And so what they do is they make a product in a lot of cases. And so when you think about the ALPL gene, its product is that ALP enzyme that we've been referring back to. So I know this is kind of complex to think about. It's all very, very small things and it's hard to visualize them, but essentially the bottom line is the ALPL gene, we all have that gene. It's only when it's working properly that it's able to make ALP. Now when there's a mutation or a variation in that ALPL gene, that's when things can kind of essentially go wrong and that enzyme isn't made properly. And we'll talk a little bit more about that in just a moment. All right, so this is just reiterating each gene and its job. So whenever ALPL is functioning properly, that enzyme is made, it contributes to normal growth. But if there's an error in the instruction manual, think about a page missing or a spelling mistake, and the gene can't properly follow those instructions, that ALPL enzyme is not made correctly. So what is a gene mutation actually? So one thing I want to point out is there's a lot of different terms that we use in genetics, and these are often used interchangeably, and different people will use different versions of it, but this is just kind of a way to think about it. A mutation just is a change. So mutate literally just means change. Not always bad, not always good, sometimes benign. And variant is also a term used, and they all kind of mean the same thing, just a variation or a change in the gene. So simply a change of the instructions, and I've got a couple of examples of what that might look like. So the correct instruction is place A on top of B, and then B on top of C. That's the instruction for how to mix the ALP enzyme, for example. You can have a mutation that's a literal spelling change. You can see A here has been changed to C. So place C on top of B, and then B on top of C. That instruction no longer makes sense, so I would not be able to follow that instruction. You can also have deletions within a gene. So a deletion of a certain set of instructions. So if you think about tearing a page out of an instruction manual, you're probably not going to be able to make your final project. So with this deletion, the instruction now says place A on top of C. Now that instruction makes sense. Okay, I'll place A on top of C, but I'm not going to get the product that I'm supposed to get whenever I have that kind of mutation. And then the last one is just multiple spelling changes, or if you change one letter, it can lead to changing the rest of them as well. So this would be kind of a backwards version of the instruction that we've got. So place B on top of A, and then C on top of B. So it's flipping the instructions around, and you end up with a totally incorrect product than what you were going to start with. So those are just some simple examples of how to think about a gene mutation. Well, where do we keep track of all of these? They are in the tissue nonspecific ALP gene mutation database, which is managed by Dr. Mornay, a French scientist who maintains this really beautiful database of specific mutations in ALPL. Now, Dr. Kisnani pointed out that there are some mutations that are more common in certain ethnic groups. So we have, for example, the Canadian Mennonites. There's a really common mutation. In the Japanese population, there's a common one. In the United States, it's a little bit more challenging because there's a lot of different ethnic groups in the U.S., and so we therefore see a bunch of different gene mutations in the population. But there are over 400 described gene mutations. I think there's 410, and as you can see, it's kind of small, but as you can see, this is updated pretty regularly. It was last updated in May, at the end of May 2020. So a really good quarantine activity, if you ask me, is keeping gene mutation databases updated. But this is where we go to find out, well, what do these mutations do? What do we know about them? And because there are so many, it's really hard to know the answer to that question, and that really kind of goes back to what I said before about how even members of the same family. So presumably even those with the same genetic mutation or gene variation can have different symptoms. So really, really good place to kind of document, have these mutations been seen in the literature? What kind of symptoms did these people have? Was it recessive? Was it dominant? Did they require treatment? Have they done studies in the lab for these specific mutations? So a lot of information there. And I do see somebody asking for the website for that, so hopefully we can get that out to you guys. It's a very, very big web page with a lot of information on it. So it can be a little bit of a challenge to read, but it's super great information, and it's being constantly updated as we learn more about different mutations. So in terms of genetics, kind of the bottom line that I like to put across, if you say, well, Erin, why are you telling me all of this? What do I really need to get out of it? It's this. Mutations or genetic changes in the ALPL gene lead to decreased or abnormal ALP enzymes, which then leads to poor bone and bone and tooth development, which of course is what causes the physical symptoms of HPP. So if you want the short SparkNotes version, this would be the slide I'd say to focus on. And it sounds very simple when you put it like that, but there's still so much that we're learning about HPP and these specific mutations that more and more is learned every single day, and this graph or this arrangement here is a lot more complicated than what I put on the slide, but as we learn over time, I think we're going to find out a lot of different things, especially other genes that might modify ALPL, or what is that ALP enzyme actually doing? How is it affecting the muscles? How is it affecting the kidneys? There's lots we still aren't totally sure about yet. So a question I hear a lot is, okay, I have HPP, how did I get this mutation, or how did my child get this? Did I pass it on? Did my mom pass it on to me? And so I always like to point out that whenever you talk about a genetic condition, genetic doesn't always mean inherited. Sometimes gene mutations just happen by chance at the time of conception. I mentioned Down syndrome before, that entire extra 21st chromosome. Typically not something inherited, it's something that just happens. But HPP is inherited and is passed down through families. There are some rare cases of new mutations, but the vast majority of the time it's something that is passed down. It can be inherited as a dominant condition or as a recessive condition. And I'm going to talk a little bit more about what those two things mean. It's probably terms that you've heard before, but might not have been totally sure about what that meant. And then in really rare cases, maybe less rare than we initially thought though, both modes of inheritance can be seen within the same family. And I've actually got a really great case example of that at the end of this presentation. So a really simple way to think about it is a dominant condition is caused by one gene mutation. So if you've got two copies of a gene, one from mom, one from dad, a dominant mutation or a dominant condition, there is only one mutated copy of that gene. So you've got one that's mutated over here with the X on it and one that is working normally. A recessive condition is typically caused by two gene mutations. So again, you've got those two copies and you've got one on each. So in this case, usually what happens is you inherit one mutation from each parent. So one from mom and one from dad, versus dominant, it can come from mom or dad. So this is a little graph that I find really helpful. It might be kind of hard to see for you guys because it's a little bit light on my screen, but this is representing autosomal dominant mutations. So the blue individuals or the darker colored individuals here are affected with the condition, and the light colored or the gray are unaffected. So in this case, we have a mother who has a dominant condition. Say she has dominant HPP. Then she's either going to pass down the gene copy that is functioning and normal, or she's going to pass down the one with the mutation. So there's a 50-50 chance each of her children will have the same condition that she does. So this is showing you there's a 1 in 2 chance that the child will be affected, and a 1 in 2 or 50% chance that the child will be unaffected. And so then when the affected child goes on to have children of their own, it's the same chance. Every time you have one copy of that genetic mutation, you have a 50-50 chance to pass it on. One thing I do want to point out, though, is this individual over here. I really hope you guys can see my my pointer, because otherwise I think it'll make this very difficult to follow. The patient on the right, so somebody who is unaffected, they can't pass on a gene that they don't have. So a question I get a lot is, can this skip a generation? And the short answer is no. So if you don't have a gene mutation, you can't pass it on. So this person won't go on to pass on HPP to their children, even if they don't have it. So this next picture is showing recessive inheritance. I think it's a little bit harder to follow, but what this is showing is these two parents, they each have one genetic mutation and one normal one. And so in a recessive condition, you have to have two, or we expect you to have two gene mutations. So typically people who have one copy of a recessive gene mutation are what we call carriers. And a lot of times carriers don't experience symptoms. We will touch on that a little bit more because HPP is kind of an exception to that. But typically we'll have two parents that are each carriers of the disease, and there are 4 different possibilities. The first possibility is that they both pass on their normal copy, and you have a child who is unaffected and doesn't carry a mutation at all. The next possibility is either dad passes on his mutation and mom passes on her normal copy, or vice versa, and then you have a child who is a carrier. So the carriers look similar to the parents in that they have just the one copy, but they don't have they don't have the symptom itself. I'm not sure what's going on the right here. You guys can see that there's some kind of pop-up. Okay, there we go. All right, and so then the third possibility is both parents pass down their mutated copy, and you have a child who is affected because they have 2 copies of that mutation. In the event that somebody is just a carrier and they only have the one copy, then if their partner is not a carrier, then they're not going to have an affected child. So then the mom here is the one who's a carrier, and she will either pass down the one mutation or her normal copy. So in this case, a carrier parent is only going to have either completely unaffected or carrier children. So this is in reference to if a parent is affected with an autosomal recessive condition. So again, a condition where you need to have those 2 mutated copies. In this case, all of mom's children will carry one copy of that mutation. Just the one, though, because dad doesn't have any mutations to pass on. So dad is only going to be able to pass on that normal copy, and mom is only going to be able to pass on a mutated copy. So a couple of different scenarios we could have here. Again, it's going to be different in every family, and sometimes we aren't even 100% sure what's going on in terms of the inheritance. And so we're going to talk a little bit more about that in a moment. But these graphs are really good to reference, and I'm sorry they're not as clear as I thought they were going to be. And these are slides that are put together by the Greenwood Genetics Center, who's a really, really wonderful genetic organization in South Carolina that puts together these slides to use for genetic counselors to explain these concepts a little bit better. So if you're a visual learner like me, hopefully those pictures were kind of helpful, but I'll also try to verbalize it and put it into writing as well. So first, I'm going to go back to this original slide of the different subtypes of HPP. So again, this is kind of fluid. This overlaps a lot, but this is generally what we expect. So these kind of more severe forms are typically autosomal recessive, meaning they need 2 mutations to have the disease. So if you remember Dr. Kishnani talking about the prevalence of HPP, the more mild to moderate forms, which again, we're kind of not wanting to use that term, but on the less severe end of the spectrum is far more common, around 1 in 6,000 versus 1 in 100,000 for the more severe infantile or perinatal forms. And if you think about it from a genetic standpoint, that makes a lot of sense because it's a lot more common to have just one mutation than to have 2 people who meet who are both carriers, who then go on to have a child, and then that child happens to have both of these mutations. So it's a lot less common in that regard. But these are typically autosomal recessive conditions. Childhood and adulthood onset HPP can be recessive or dominant. And so genetic testing is really important. We can make the clinical diagnosis of HPP based on low ALP or physical symptoms, but doing the actual genetic testing is really, really important, not only for your own management as a patient, but then to know, well, what are the chances I'm going to pass this on to my child? And then odonto HPP, which again we know is highly variable, is usually dominant. However, there are some exceptions to that rule, and again, that becomes very fluid whenever we reference back and say, well, odonto might not be just odonto. So a lot of the times that can change over time. Those symptoms can change over time, and you're no longer dealing with odonto and maybe childhood onset, and now all of a sudden you've got 2 genetic mutations. When typically you might have been thought to have the mild form and you had just 1. So that can change, and it's really, really important to have that information, especially when you get to a point in your life where you're wanting to have children or your children want to have children. What are the chances that this is going to get passed down? Well, this didn't work as well as I thought it was going to do. Okay, so I'm going to talk a little bit about why we can see differences between dominant and recessive HPPs. So I want to go back to my little graph here where we've got a dominant condition. So in the case of dominant HPP, you have the 1 gene mutation, and you still have 1 copy of the gene that's working. Okay, so you have at least 1 copy that's producing some normal ALP. Okay, and then in recessive conditions, when there are 2 copies, you don't have any normal copies of that gene. So you theoretically don't have any normal ALP. So I put this little graph on the side here, and again, it's kind of hard to read, so I'm sorry, but on the far left, I've imagined if you've got 2 normal copies, your ALP level will be normal. If you've got dominant ALP, it'll be decreased, but you've still got that 1 normal copy, so you could still have some functioning ALP. Or if you have recessive condition, you have no or very little functioning ALP, you're going to have a more severe presentation of the disease. So theoretically, the less ALP you have, or the less functioning ALP you have, the more severe the disease presentation might be. And so there are a couple of exceptions to this. So one of them is called dominant negative, which is a lot of the time what we might see in adults with HPP that can end up with more obvious symptoms where this mutation on the mutated copy is actually affecting the other working copy from making normal ALP. So even then, there's a lot of variation that can go on. It's not as cut and dry as dominant and recessive a lot of the times. And so understanding the actual mechanisms of these mutations, like what is this spelling change actually doing? We can see that it's a mutation. We can see that it's causing a problem, but how is it causing a problem, and what is that associated with? What is this particular mutation associated with? And so this will hopefully allow us to get a better understanding and maybe make a prediction in the future. If somebody has this specific mutation, you say, okay, I've seen this enough times that I know that it's associated with fractures and dental loss, tooth loss, and bone pain. So I kind of know to expect that in a patient. And we're not quite there yet, but we're definitely, as more information comes, as more people sign up for the registry, we are getting that information, and it's becoming a little bit easier to make those predictions. But again, that just depends on how common that mutation is. Okay, I think that this was repeated. All right, so the last thing I want to refer to is a case example of a time in which we can see dominant and recessive mutations in the same family. So this is a 5-year-old girl who is seen in the genetics clinic. She's got craniosynostosis, or that abnormal fusion of the skull, a low ALP, she's missing a lot of teeth, and she's very small. She didn't start walking until she was 2, so she's got some delayed motor milestones, but her speech and fine motor milestones were all met on time. She was going into kindergarten and was functioning, intelligence was normal. She was just very small and had some difficulty walking. So genetic testing was done based on this low ALP and pretty classic HPP symptoms, and she was found to have 2 mutations in the ALPL gene, so therefore she is diagnosed with autosomal recessive HPP. So at that time, her parents both get genetic testing and confirm that they each have one ALPL mutation that they pass on to their daughter, and so therefore they're carriers of the disease because they just have the one mutation. And typically when we think about recessive conditions, parents who are carriers don't show any symptoms and we don't really do any further testing. But a good example of this is a condition called cystic fibrosis that a lot of you guys might have heard of. It's a pretty common genetic lung disease that affects children and adults. And so if you, for example, if you're a woman who's pregnant, you might get testing prior to having your child to see if you're a carrier of CF. And so that's a really great example of a condition in which we really don't expect carriers to have any symptoms, and we're not going to usually do further testing. So this would be a very similar situation to that. So then our little girl begins treatment with enzyme replacement therapy and does very well. She starts to show improvement, doesn't have as much pain. She catches up on her motor milestones, and we go from there. And so this is just another picture of that autosomal recessive inheritance pattern where both parents are carriers, and there's that 1 in 4 chance that they're going to have a child who is affected, which would be our patient here on the right. The symbol here of the little guy in blue. So the family moves away after that initial appointment, but moves back about 5 years later in return for a follow-up visit. So the patient is now 10 years old. She's continuing to do well, and her parents are with her for her follow-up appointment. The geneticist notices that her father is wearing a boot on his right leg, and she says, "Hey, where did that come from? What's going on?" And he says that he recently fractured his foot while he was out on a run. Upon further questioning, it seems that the father has had multiple foot fractures in the last couple of years. And he's actually had to start working from home due to increased pain and fatigue. And this has all happened in the last couple of years. When the geneticist first met them at their initial appointment, both parents were healthy. They both were active. They both had jobs and didn't really have any health problems. But the father of this patient continued to show some worsening over time and getting these multiple fractures. So the geneticist, of course, orders an ALP level on the father, and it is found to be below that normal reference range. So the geneticist goes back and reviews the patient's and parents' original test reports from 5 years ago, and at that time there wasn't a whole lot of information on those specific gene mutations that were found in the patient. But more evidence has been gathered since then, and if you went back and looked into that mutation registry that we talked about before, more and more people had come forward and had that same mutation as the father, and a lot of those patients actually just had the one mutation and were diagnosed with hypophosphatasia. It is also was seen in cases like the daughter, where it was seen in conjunction with another mutation in the form of a recessive HPP. So the father then got further workup. What we typically do, we're looking at those biomarkers, the urine PEA and the PLP, DEXA scan and x-rays to look for other factors, and he was formally diagnosed with autosomal dominant HPP at that point. So then the mother was checked out, and she also had some mildly decreased ALP, but no clinical symptoms were really described for her. She didn't have any fractures, she had normal dentition, and wasn't really experiencing any pain. And her specific mutation didn't really have a lot of reported cases. I think there was 2 or 3 that were autosomal recessive, just like in her child. So what did we learn from this case? So this case is in itself fictional, but based off of our anecdotal experiences here at Duke. I based it off of a couple of different families that we've seen, and this is not an entirely uncommon phenomenon. So HPP is not like a typical recessive disorder. So when you as parents are told you're carriers, or your child is affected and you're told their siblings are carriers, that's not the kind of typical definition we associate with a carrier. You simply think, oh, I'm just a carrier, I don't have symptoms. But in HPP, it's possible that you're a carrier who has a dominant form of the disease, and you've just got that one mutation, but we later find out it's causing these symptoms, especially since we know that they can appear later on in life. So the bottom line here is that full workup should be done besides genetic testing. So now that we know this information, if we could go back 5 years, what we would have done is further workup on the parent aside from just the genetic testing, doing biomarkers, looking at ALP, doing an x-ray to look for maybe some hidden fractures, asking more specific questions to the parents. Well, have either of you experienced any pain? I think a lot of the times when you parents are coming in with their children, your child is sick. There's something wrong. You're very worked up about it, and all of your focus is on that child. And your focus typically isn't on yourself. You might be thinking, oh, well, yeah, I did have a lot of fractures when I was a kid, or my teeth did come out really early. Maybe later on that might come to your mind, but in that moment you're so focused on your child that that kind of all gets pushed to the back burner. And so geneticists and genetic counselors are really spending a lot more time nowadays asking more targeted questions to the parent, and then doing a full genetic workup on them as well, just to be sure that we're not missing a diagnosis in a parent. And then again, just to kind of beat the point that symptoms can arise at any point in the lifespan. So even if we do a full workup and there's nothing wrong now, I'm still going to want to monitor you over time, especially maybe the mom. Her mutation is not very well studied, therefore it's really difficult to have any answers for her. So I want to continue to watch her closely over time. And of course the father, now might qualify for treatment with Strensic. And so this kind of puts the example of somebody who maybe was asymptomatic and of course didn't get treatment until well after he's experienced several fractures and some debilitating pain and is now unable to work. So the goal is to make that diagnosis and start monitoring for symptom onset before it gets to that point. So as a patient, you might be thinking, well, what can I do to help the community, the scientific community, and to help myself? So the very first thing is my biggest advice to any patient with a rare disease is you have to learn how to advocate for yourself. I can't tell you how many patients come to us and say, well, my rheumatologist, my primary care, my OB, all those people, they don't know anything about HPV. They don't know, and I'm the one who has to educate them. And that's going to be a pretty common experience. Rheumatologists are probably some of the most experienced with HPV because of symptom overlap so much. But if you're taking your child to their general pediatrician, they might not have a ton of background knowledge of HPV. And you as the parent or the patient in these situations are going to have to advocate for yourself a little bit and to provide some literature and to stand up and say, well, no, I need this for myself, I need this for my child. And while we were in between sessions, I was looking at the Resource Center on the Software conference page, and there's a lot of really great information on there. So having that stuff printed and ready to take to the doctor is going to be super, super helpful. So besides from helping yourself, you can also help us, the scientific and the medical community. Honestly, the best way to do this is to sign up for the registry. It's a very, very simple thing. No blood draws needed, no poking and prodding. It's just giving us information on your specific mutation and your symptoms. And that kind of helps us build a more detailed database of, well, what is this mutation specifically associated with? Is it seen in the dominant case? Is it seen in only recessive? Do these people have more fractures than people with a different mutation? And that kind of information is invaluable when we're trying to learn more about HPV. And last but not least, I of course recommend always coming to meetings like this. It is extremely helpful in the world of rare disease to have a community, not only of medical providers and doctors, but of course having that patient community. It's really, really helpful to lean on each other and to educate each other and advocate for each other. Of course, your experience might be very, very different from theirs. Even, like I said, even as siblings or parent and child can have very different manifestations. So you can continue to learn from us, you can continue to learn from each other, and we can continue to learn from you. We definitely couldn't have this knowledge or have these presentations without the input from the patient community. And so I'm always just incredibly thankful and impressed by the resilience of the HPP community specifically. So thank you so much for your attention and for joining my session here. I see that there's lots of participants, and I'm really excited that, that this video platform worked really, really beautifully. My biggest advice right now, I have a feeling we'll probably get a lot of questions at the end of the day on COVID and HPP. But my overall advice is to stay home and stay well, wear your mask when you go outside if you can, and not only take care of your physical health, but your mental health as well. I expect that I will get lots of people asking about how do we get an appointment with Dr. Krishnani or with the Duke team. And so if you'd like to do so, you can send me an email and I will get you connected to the right people if you would like to get established as a patient. This one will probably be virtual for now. but that's my email address there. You're also welcome to contact me with any follow-up questions related to this presentation. And so with